we are going to start the oncology, and in oncology, first we are going to discuss the soft tissue sarcoma. So see the one-liner questions which are frequently asked related to soft tissue sarcoma. First question, that what is the most common type of soft tissue sarcoma? See, initially it was malignant fibrous histiocytoma, but according to 11th edition of DeVita and Schwartz, it is liposarcoma followed by leiomyosarcoma. Okay, so first, what is the most common type of soft tissue sarcoma? Most common type of soft tissue sarcoma, and it is liposarcoma followed by leiomyosarcoma. Okay, liposarcoma followed by leiomyosarcoma. Next, what is the most common type of soft tissue sarcoma in extremities? So in extremities, it is malignant fibrous histiocytoma. Next important point, most common soft tissue sarcoma in extremities. Clear? So in extremities, this is malignant fibrous histiocytoma. Third important point, what is the most common type of soft tissue sarcoma in children? And in children, it is rhabdomyosarcoma. So important point, most common type of soft tissue sarcoma in children, right? This is also frequently asked question, and this is rhabdomyosarcoma. Okay, in INI-CET 2020 there was one question, that what is the most common type of retroperitoneal sarcoma or most common type of retroperitoneal tumor? So most common type of retroperitoneal sarcoma or retroperitoneal tumor is liposarcoma. So most common type of retroperitoneal tumor or retroperitoneal sarcoma. Clear? And this is what? Liposarcoma. Liposarcoma. These are one-liner questions related to the types of sarcoma. Now see the questions related to site. So overall, what is the most common site of soft tissue sarcoma? So most common site of soft tissue sarcoma. So overall, most common site is extremities. So it is extremity. And you have seen that in upper and lower extremity, soft tissue sarcoma is more commonly seen in lower extremity. Okay, so if we compare, it is more common in lower as compared to upper extremity. So it is followed by trunk, followed by retroperitoneum, followed by head and neck. Clear? So overall, most common site of soft tissue sarcoma is extremity, more common in lower extremity, followed by trunk, followed by retroperitoneum, followed by head and neck. Now there are certain basic principles which are going to apply for most of the sarcomas. First, in soft tissue sarcoma, what is the most common route of spread? It's hematogenous. We discussed that in adenocarcinomas, the most common route of spread is lymphatic, and generally in sarcomas, the most common route of spread is hematogenous. And via hematogenous spread, what is the most common site of metastasis? It is lungs. But if we are talking about the retroperitoneal sarcoma, retroperitoneal sarcomas whose major drainage is going into portal vein and via portal vein into liver. So despite of having hematogenous spread, if the malignancy is in the retroperitoneum, so for retroperitoneal sarcoma, most common site of metastasis is liver followed by lungs. Similarly, investigations. If you're talking about the investigation of choice for diagnosis of soft tissue sarcoma, it is true cut biopsy or core cut biopsy, right? And if we want to assess the extent of soft tissue sarcoma, and for extent of soft tissue sarcoma, the investigation of choice is MRI. But if we are talking about retroperitoneal sarcomas, for retroperitoneum or for retroperitoneal pathologies, investigation of choice is CT. So investigation of choice for diagnosis remains core cut biopsy or true cut biopsy, but investigation of choice to assess the extent of retroperitoneal sarcoma becomes CCT. Clear? These are the basic principles we are going to discuss one by one. So in soft tissue sarcoma, what is the most common route of spread, most common route of spread in soft tissue sarcomas, and that is hematogenous. Okay, so most common site of metastasis, the most common site of metastasis, and that is lungs. So most common site of metastasis in soft tissue sarcoma, and this is lungs. What we discussed in retroperitoneal sarcoma, it is liver. So most common site of metastasis in retroperitoneal sarcoma, and here the answer is liver. So in retroperitoneal sarcoma, it is liver. We discussed that in soft tissue sarcoma there is hematogenous spread. Lymphatic spread is usually not seen, so it's rare. So the question is asked that what are those soft tissue sarcomas in which there is lymphatic spread? So important point, soft tissue sarcomas associated with lymphatic spread. Okay, and it is very easy to remember. Why? Because there is a mnemonic, and the mnemonic is Marses. So the mnemonic is Marses. So what is the full form? M, malignant fibrous histiocytoma. A, angiosarcoma. R, that is rhabdomyosarcoma. C, that is clear cell sarcoma. Clear cell sarcoma. E, epithelial sarcoma. S, synovial sarcoma. So E is epithelial sarcoma and S is synovial sarcoma. Clear? These are the sarcomas which are having lymphatic spread. So if the tumor is having lymphatic spread, there is lymph node metastasis, and if there is lymph node metastasis, in surgery what is required? Lymph node dissection. So question is being asked in three ways: sarcomas associated with lymphatic spread, or sarcomas associated with lymph node metastasis, or sarcomas which require lymph node dissection. Clear? So since there is lymphatic spread, it leads to lymph node metastasis, and since there is lymph node metastasis, what is required? Lymph node dissection. Clear? So these are the questions related to spread. Now see the questions related to diagnosis. So related to diagnosis, we discussed what is the investigation of choice for diagnosis, and the investigation of choice for diagnosis is the biopsy. What kind of? True cut biopsy or core cut biopsy. So this is true cut biopsy, also known as core cut biopsy. Clear? So you need biopsy. Investigation of choice to assess the extent. Investigation of choice to assess the extent of soft tissue sarcoma. Okay, so for soft tissue tumors, generally which investigation is preferred? MRI. So we go for MRI. But see the twist in the question. If we want to assess the extent of retroperitoneal sarcoma, then the investigation becomes CCT. So here, see the change. Investigation of choice to assess the extent of retroperitoneal sarcoma. So here the answer is CCT. Clear? Where are the variations between soft tissue sarcoma and retroperitoneal sarcoma? In soft tissue sarcoma, most common site of metastasis is lungs. Retroperitoneal sarcoma, most common site of metastasis is liver. Investigation of choice to assess the extent of soft tissue sarcoma, MRI, and retroperitoneal sarcoma, it is CCT. Now see the one-liner questions related to prognosis. We discussed in previous chapters that the most important prognostic factor in most of the malignancies is stage. Why? Because stage includes T and M. See, important point. Most important prognostic factor for most of malignancies. Clear? And that's stage. Why? Because in stage we are going to include T and M. What are the exceptions we discussed? First exception is Wilms tumor. In Wilms tumor, the most important prognostic factor is what? Histology, followed by stage. And the second is soft tissue sarcoma. In soft tissue sarcoma, what is the most important prognostic factor? And that's grade. Clear? So what are the exceptions? Exceptions. Clear? And the exceptions are first Wilms tumor. In Wilms tumor, the most important prognostic factor is its histology followed by stage. Clear? And the second is soft tissue sarcoma. And in soft tissue sarcoma, the most important prognostic factor is grade. What is the grade? Clear? So why grade is most important prognostic factor in soft tissue sarcoma? Because grade is the most important predictor of metastasis. In soft tissue sarcoma, grade is the most important predictor of metastasis, and metastasis is the most common cause of death in soft tissue sarcoma. And that's why what is the most important prognostic factor in soft tissue sarcoma? It's grade. So grade is the most important prognostic factor in soft tissue sarcoma. Why? Because this is the most important predictor of metastasis. Predictor of metastasis. Clear? And you know that most common cause of death in soft tissue sarcoma is the metastasis. Metastasis is the most common cause of death in soft tissue sarcoma. Clear? So these are the one-liner questions which are frequently asked. Clear? Now in detail we are going to discuss the soft tissue sarcoma. So soft tissue sarcoma. So we discussed that what is the most common type of soft tissue sarcoma, and the overall most common type is liposarcoma followed by leiomyosarcoma. So the most common type is the liposarcoma followed by leiomyosarcoma. Okay, now see, the histopathological type of soft tissue sarcoma is dependent on the site. So it is site dependent, right? Now see, if you're talking about extremities, what is the most common type of soft tissue sarcoma? This is malignant fibrous histiocytoma. If we are talking about the retroperitoneum, most common type liposarcoma. And if we are talking about viscera or GIT, then it is GIST. So histopathological type is site dependent. Histopathological type, it's site dependent. Clear? Now if you are talking about the site, see, in extremities, what is the most common type? It's the malignant fibrous histiocytoma. In the retroperitoneum, most common type, it is the liposarcoma. Clear? And in the viscera or GIT, it is GIST. What is the full form of GIST? Is the gastrointestinal stromal tumor. Now see the pathological aspect. The soft tissue sarcoma is going to expand along the facial planes. So if it is going to expand along the facial plane, it is going to compress the surrounding tissue, and because of this compression of surrounding tissue, there is formation of a pseudo-capsule around the tumor. So generally in soft tissue sarcoma, there is pseudo-capsule formation because it tends to grow along the facial planes. One. Second, the clinical behavior of the soft tissue sarcoma is dependent on what is the location or depth, what is the grade of tumor, and what is the size at the time of presentation. Okay, so see the pathological aspects related to soft tissue sarcoma. So we discussed that this tumor is having a pseudocapsule because of compression of surrounding tissues. Second, the clinical behavior is dependent on the clinical behavior of tumor. It's dependent on location or depth. So what's the location? grade. Why? Because grade is most important predictor of metastasis. And third, size at the time of presentation. Okay. Now see the clinical features. What is the most common presentation? If you have seen a patient of soft tissue sarcoma, generally you have noticed that what is the most common presentation? These patients are having painless mass. Now the size of tumor is dependent on the location. If the tumor is located in extremities, especially in the lower extremities, what happens? Generally patient is having a small mass and then patient is coming to you. But if the tumor is located in the proximal extremity or in the retroperitoneum, these tumors are very large at the time of presentation. Okay, so clinical features. What's the most common presentation? And the most common presentation is painless mass. It's the painless mass. Usually it's large, but size is dependent on the location. Clear? Now see, size is dependent on the location. So if we see the tumors in distal extremity, so in distal extremities it's relatively smaller, right? And if you're talking about proximal extremities or retroperitoneum, the tumor is very large, so it's larger. So in proximal extremities or in retroperitoneum, here the tumor is larger. Clear? So in retroperitoneal sarcoma, what is the presentation? There is large painless mass. Basics of soft tissue sarcoma we already discussed, that generally the most common route of spread is hematogenous, most common site of metastasis, and that is lungs. Now coming to the diagnosis, and we discussed this aspect also, that investigation of choice for diagnosis is true cut biopsy or core cut biopsy. Investigation of choice to assess the extent of soft tissue sarcoma, MRI, and extent of retroperitoneal sarcoma, that is CCT. Clear? So investigation of choice for diagnosis, and that's true cut biopsy or core cut biopsy, right? Investigation of choice to assess the extent, to assess the extent. Clear? So in soft tissue sarcoma, it is MRI. Here it is MRI, and in retroperitoneal sarcoma, this is what? CCT. Now coming to the treatment. See, in soft tissue sarcomas, we give the multi-modality treatment usually. So it's the combination of surgery plus radiotherapy plus chemotherapy. Okay. So what are the options which we are having for the treatment of soft tissue sarcoma? Surgery, radiotherapy, and chemotherapy. What is the principle we follow in surgery? Generally, in surgery, we have to go for wide local excision with 2 cm margin. Okay, so we have to achieve the clear margins. So there should be adequate clear margins. Sometimes it's difficult to achieve the clear margins, and if it's difficult, then we can go beyond the compartment to resect the tumor. So this question was asked in JIPMER, in which tumor resection is done even beyond the compartmental margins, and it is done in soft tissue sarcoma. Okay, so treatment aspect, treatment of soft tissue sarcoma. So generally we go for surgery plus radiotherapy plus chemotherapy. We have all these 3 options. Okay, now see in detail what are the options available. So in surgery, radiotherapy and chemotherapy. In surgery, we go for wide local excision. How much margin? Wide local excision with 2 cm margin. Clear? So what we have to achieve? Achieve the clear margin. If it's not possible to achieve the clear margin, in this case, we can go for resection beyond the compartmental boundaries. Resection beyond the compartmental boundaries. And this was the question which was asked in JIPMER. It was direct one-liner question, that resection beyond the compartmental boundaries is done in which particular tumor? Soft tissue sarcoma. For radiotherapy, we have 2 options, we can go for external beam radiotherapy and intensity modulated radiotherapy. EBRT, external beam radiotherapy, IMRT, intensity modulated radiotherapy. And in chemotherapy, what are the agents which are most commonly used in soft tissue sarcoma? It's the doxorubicin and ifosfamide. Doxorubicin and ifosfamide. Why soft tissue sarcoma is very close to my heart? Because I got a long case of soft tissue sarcoma in my MS exam, and I got the highest marks in long case presentation. Clear? So soft tissue sarcoma, the most important chemotherapy agents or most commonly used agents are doxorubicin and ifosfamide. Now coming to the prognosis, and there is a simple principle to remember this. See, whatever the tumor is there, if the tumor is detected early, usually the size is smaller. So if the tumor is detected early, usually the size is smaller, and if it's detected early, it's treated early. So whatever the tumor which is smaller in size, detected early, treated early, these are having better prognosis. So if you see the description, which tumors were relatively smaller? Extremity sarcomas. Why? Because they are detected earlier. So that's why best prognosis is dependent on the site, and extremity sarcomas are having best prognosis. So first, best prognosis is seen in extremity sarcoma. So best prognosis, it is seen in extremity soft tissue sarcoma. First, second, we discussed what is the most important prognostic factor in soft tissue sarcoma. It's grade. Why? Because grade is the most important predictor of metastasis, and the most common cause of death is metastasis in soft tissue sarcoma. So most important prognostic factor, and that's grade. Why? Because grade is most important predictor. This is most important predictor of metastasis, right? And you know what is the most common cause of death in soft tissue sarcoma? So most common cause of death in soft tissue sarcoma, and that's metastasis. Clear? So these are the questions which are related to prognosis. We discussed what is the most common type of pediatric soft tissue sarcoma, and that is rhabdomyosarcoma. Rhabdomyosarcoma is asked in pediatrics also, it is asked in surgery also, and pathology also. So we will discuss this tumor in detail. Rhabdomyosarcoma. Rhabdomyosarcoma. Okay. So first, what's the most common type of pediatric soft tissue sarcoma? So this is most common type of pediatric soft tissue sarcoma. Okay. So in rhabdomyosarcoma, what is the most common site? Is the head and neck. So what is the most common site of rhabdomyosarcoma? And this is head and neck. In head and neck, exactly where? It's parameningeal. What site? Parameningeal. So after head and neck, it is seen in second most common site is the extremity, followed by genitourinary tract, followed by trunk. So most common site is head and neck, followed by extremity, followed by genitourinary tract, followed by trunk. Clear? Now see, what is the most common type of rhabdomyosarcoma? And the most common type is embryonal variety. So if you see the pathological aspect, these are the important points which are asked in pathology. The most common histological type, most common histological type of rhabdomyosarcoma, and that is embryonal variant. So it's the embryonal variant. Clear? But if we are talking about the most common type of histological type in adults, and this is pleomorphic variant. Clear? So the most common histological type of rhabdomyosarcoma in adults, and this is pleomorphic variant. Pleomorphic. So you have to remember these histological types. Now the name of this malignancy is rhabdomyosarcoma. The name is rhabdomyosarcoma. So what is the name of diagnostic cell? It is the rhabdomyoblast. Okay. So what is the diagnostic cell in rhabdomyosarcoma? It is the rhabdomyoblast. There is rhabdomyoblast. Clear? What are the other cells which are seen and asked in exam? There is tadpole cells, presence of strap cells. So there are other cells which are asked. Tadpole cells, looks like tadpole, strap cells. So here we discussed what is the most common type is the embryonal variant or embryonal rhabdomyosarcoma, and in this embryonal rhabdomyosarcoma there are two variants. One is spindle cell variant and one is sarcoma botryoides. And you must remember that question which is asked in pathology related to sarcoma botryoides, that the tumor cell appears like tennis racket. Clear? So in embryonal rhabdomyosarcoma, if you see embryonal rhabdomyosarcoma, clear, there are two variants. One is spindle cell variant, clear, and second is sarcoma botryoides. This is frequently asked in exams. Okay, sarcoma botryoides. And what is the question which is asked related to sarcoma botryoides? That here the tumor cell is having which appearance? Tennis racket appearance. So there is tennis racket appearance of tumor cell. This is the question which is frequently asked. Now coming to clinical features of rhabdomyosarcoma. See, it is bimodal. So if you see the first peak is seen in 2 to 5 years of age, and the second peak is seen in 15 to 19 years of age. Rest of the features are almost similar to soft tissue sarcoma. Means, see, what is the most common presentation in rhabdomyosarcoma? It is painless mass. But generally it's rapidly growing. So it's rapidly growing painless mass. What is the most common route of spread? Hematogenous. What is the most common site of metastasis? Lungs. What is the investigation of choice for diagnosis? True cut biopsy or core cut biopsy. And what is the investigation of choice to assess the extent? It is MRI. So these are similar. So generally it's bimodal, okay, and the first peak is seen between 2 to 5 years, and the second peak is seen between 15 to 19 years, right? What is the most common presentation? And the most common presentation is rapidly growing painless mass. It's rapidly growing painless mass. It can be painful also, but the most common presentation is painless mass. So it's rapidly growing painless mass. Rest of the features are similar. So the most common route of spread, hematogenous, most common site of metastasis, lungs. Now coming to the diagnosis, it is also similar. Investigation of choice for diagnosis, and that is true cut biopsy or core cut biopsy. Investigation of choice to assess the extent, and that's MRI. Investigation of choice to assess the extent of rhabdomyosarcoma, and that is MRI. Now see the basic principles which we follow in the treatment of rhabdomyosarcoma. If the tumor is resectable, we go for resection and we go for wide local excision with 2 cm margin. Simple. If the tumor is unresectable, we have to downstage the tumor. So generally how we are going to downstage the tumor? We go for neoadjuvant chemotherapy. So we first go for neoadjuvant chemotherapy and then we go for wide local excision. Second, in certain situations, it's not possible for you to remove the whole tumor. And sometimes we have to leave some part of tumor inside, or sometimes because of mistakes the positive margins are there, means tumor cells are left inside. So whenever there is positive margin, in these cases, to prevent the risk of recurrence in post-operative period, what should be given? Radiotherapy. So I'm repeating, tumor is resectable, we go for wide local excision with 2 cm margin. Unresectable tumor, downstage it with neoadjuvant chemotherapy followed by wide local excision, and if positive margins are there, we go for post-operative radiotherapy. So the treatment for resectable tumor, if it's resectable, we go for wide local excision with 2 cm margin. Clear? If it's unresectable, in unresectable tumors, we go for neoadjuvant chemotherapy, okay, followed by surgery. So we go for wide local excision. And third situation, if there is positive margins, so after surgery tumor is still left in the body, and in these cases we go for post-operative radiotherapy. So this is how we are going to manage. Now coming to the prognosis. In this case, the prognosis is dependent on the type, histological type, and the site, means location. So see, questions related to prognosis. Prognosis is dependent on type and site. Clear? So if you're talking about the type, which type is having favorable prognosis? Is the embryonal variant. So embryonal variant, which is the most common type, and that is having favorable prognosis, and the alveolar variant is having unfavorable prognosis. Clear? So embryonal variant, this is having favorable prognosis. Clear? And alveolar variant, this is having unfavorable prognosis. Right? Now see the site. What are the favorable primary sites and what are the unfavorable primary sites? So first, sites, favorable primary sites and unfavorable primary sites. Clear? So in head and neck, what is the favorable primary site? It is non-parameningeal. And what is unfavorable primary site? It's parameningeal. So unfavorable is parameningeal and favorable is non-parameningeal in head and neck. Non-parameningeal. What are the other favorable primary sites? It's the paratestis, orbit and vagina. Clear? And what's the other unfavorable sites apart from parameningeal? Is the extremity. Clear? So you can easily remember unfavorable sites because only two are there, parameningeal and extremity, and the favorable are non-parameningeal, paratestis, orbit, vagina. So how to remember? Mnemonic is NPO vagina. So it's NPO vagina. Clear? So these are the important points related to rhabdomyosarcoma. Now see this tumor. What you can see here? You can see that there is nodular cutaneous mass. Can you see? The nodular cutaneous mass. And if you see, there is protrusion, means the level of tumor is above the level of surface of skin. So there is nodular cutaneous mass with protrusion. Clear? And what is the name of this tumor? The name of this tumor is DFSP, dermatofibrosarcoma protuberans. This is very important tumor, and this is very hot tumor nowadays, because in most of the exams there is 1 or 2 questions asked related to this tumor. So this tumor is DFSP. In short, it's known as DFSP. The full form is dermatofibrosarcoma protuberans. Okay, the term is self-explanatory. Okay, so here dermato means this tumor is going to involve dermis and subcutis. So what? This tumor is going to involve dermis and subcutis. Okay, so dermato. Second, it is a type of sarcoma. What kind of sarcoma? It's a type of low-grade sarcoma. So the term is fibrosarcoma. So it's a type of low-grade sarcoma. And since it's a low-grade sarcoma, there is metastasis, but it is rarely seen. So in low-grade sarcomas, rarely metastasis is seen. Okay, so rarely it is going to metastasize. Right? But what is the problem? This tumor is having radial extensions or having finger-like extensions into the subcutaneous tissue. So if there is finger-like extension, what is the problem? Because of this radial extensions, there is increased risk of recurrence. So the main problem that whenever we are going to resect the tumor, it recurs locally. So why this tumor recurs locally? Because of radial extension into, there are radial extensions into subcutaneous tissue. So it rarely metastasizes, but it recurs locally because there is radial extension into the subcutaneous tissue. Okay, and protuberance means there is protrusion. So we are going to discuss it again. Dermato, so it is going to involve dermis plus subcutis. Fibrosarcoma, so it's a type of low-grade sarcoma, rarely associated with metastasis, but it recurs locally because there are presence of radial extensions. And if you see the level, it is having protrusion, so that's why it is dermatofibrosarcoma protuberans. Next question, that what is the most common site? And if you see the most common site, it is trunk. After trunk, it's the extremities, and after that, head and neck. Clear? So the most common site, in 50% cases, it is seen in trunk, followed by extremities. It is seen in 30% cases, followed by head and neck. Head and neck in 20% cases. Clear? So how to remember? The mnemonic is 10. 10. Trunk, extremities, neck means head and neck. Clear? Now see the pathological aspect, because in pathology also lots of questions are asked. These tumors are associated with satellite nodules, and it is CD34 positive. Third point, that in more than 75% of patients there is presence of ring chromosome. So how this ring chromosome is going to be formed? It is formed by translocated portion of chromosome numbers 17 and 22. Okay, so important points related to pathology. First, that these tumors are having satellite nodules. So there is satellite nodules. These tumors are CD34 positive, and there is presence of ring chromosome. In how many patients there is presence of ring chromosome? This is present in more than 75% of patients. Clear? And how this ring chromosome is formed? It is formed by translocated portion of chromosome number 17 and 22. So it is formed by or composed of translocated proportion of chromosome number 17 and 22. Now see the most important aspect related to this tumor. Now here you can see this blue colored tumor, and if you see, this tumor is having radial extensions. Can you see? So these radial extensions are for long distances from the primary tumor, and because of this finger-like extension or radial extension, if we are just going for ordinary resection, imagine that I am going to resect the tumor. What is the problem? Because of these extensions, there is high risk of local recurrence. That's why whenever we are planning the resection of this tumor, what kind of resection is done? You can see here we perform the circumferential resection. Clear? And whenever we perform the circumferential resection, how much margin is taken? We are going to take 2 to 4 centimeter margin around the tumor circumferentially. Right? So what is the main problem here in this tumor? That it is having radial extension. Clear? So you can see here there is radial extension. And because of this radial extension, this tumor can permeate for long distance from the primary tumor. So it can permeate through long distance. So there is permeation for long distances from the primary tumor. And because of this, there is increased risk of local recurrence. Simple. So how we can prevent this local recurrence? If we go for wide local excision with circumferential margin. So there is circumferential margin, how much? 2 to 4 centimeter. This question was asked in a super specialty exam, that which of the following tumor requires maximum margin? So DFSP is one of those tumors which requires 2 to 4 centimeter of circumferential margin. Now see the clinical presentation. So we discussed that what kind of growth is there. These patients are having nodular cutaneous mass. So there is nodular cutaneous mass, and you can see there is protrusion. Clear? In these tumors there is slow and persistent growth. Slow and persistent growth. So there is growth over a long period of time, and because of that, what you are going to notice? You are going to notice the protrusion. Right? So there is slow and persistent growth. Clear? And because of this slow and persistent growth, this lesion enlarges over many years. So enlargement of lesions. And because of this enlargement of lesions, what you will notice in these tumors? Yes, you will notice the protrusion, and that's why it is known as protuberance. Clear? Dermatofibrosarcoma protuberance. How we are going to make the diagnosis? Generally we go for the biopsy. What kind of biopsy is done here? Here we go for incisional biopsy. Incisional biopsy. Clear? So diagnosis. Investigation of choice for diagnosis, it's the incisional biopsy. Clear? And what is the treatment? Wide local excision with 2 to 4 centimeter of circumferential margin. Simultaneously, we have to remove the underlying fascia also. So see the treatment. This is the most important aspect. We go for wide local excision with how much margin? 2 to 4 centimeter of circumferential margin. Clear? Plus removal of underlying fascia. Otherwise, there is local recurrence. Clear? First, plus removal of underlying fascia. This is the treatment. Now imagine there is advanced and unresectable dermatofibrosarcoma protuberance. Advanced and unresectable. In these cases, we give an agent, and that is first line agent. It is imatinib. So what is the first line agent for advanced and unresectable dermatofibrosarcoma protuberance? It is imatinib. We discussed that imatinib is also used in GIST. So it's the first line agent for GIST. It is the first line agent for CML. So at 3 places we use imatinib mesylate. So what is the first line agent? So the first line agent for advanced and unresectable DFSP. and this is imatinib. Clear? So one of the indication is what? Advanced and unresectable DFSP. Imatinib is the first line agent for GIST as well as CML. GIST is gastrointestinal stromal tumor, CML is chronic myeloid leukemia. So this is how we are going to manage DFSP. It's very, very important. You will get 1 or 2 questions related to this in one of the exam. Now we are going to discuss oncological emergencies. Okay, and what are the oncological emergencies which are very, very important and generally asked in exam? Yes, first is tumor lysis syndrome. There is hypercalcemia of malignancy. There is typhlitis, which is also known as neutropenic colitis, and fourth is superior vena cava syndrome caused by superior vena cava obstruction. Right? So one by one we are going to discuss. First of all, we are going to discuss the tumor lysis syndrome. Tumor lysis syndrome. Okay, so the term is self-explanatory. What's the problem here? It is the syndrome or group of symptoms caused by lysis of tumor cells. So tumor cells means rapidly proliferating neoplastic cells, and there is lysis of or mass destruction of these tumor cells and leading to signs and symptoms that's known as tumor lysis syndrome. So why there is mass destruction of these rapidly proliferating cells, neoplastic cells? Because we give chemotherapy. Clear? So what's the problem here? It is the syndrome caused by lysis of tumor cells, means there is destruction of, it is caused by destruction of large number of rapidly proliferating neoplastic cells. Clear? And generally why there is destruction of these cells? Because we gave chemotherapy. Okay, so especially the malignancies in which we give chemotherapy, and chemotherapy is the main treatment option, tumor lysis syndrome is generally associated with those malignancies. So what are the malignancies in which this tumor lysis syndrome is commonly seen? So this is most commonly associated with, first, high-grade lymphomas, high-grade lymphoma, chronic leukemia, chronic leukemia. You have seen children suffering from ALL in which we give chemotherapy, so acute lymphoblastic leukemia and Burkitt's lymphoma. Okay, these are the common malignancies in which tumor lysis syndrome is seen. And how to remember? It's very easy. Can you see? High CAB. So the mnemonic is high CAB. Okay. Now see what is the pathophysiology. Whenever there is destruction of large number of cells, so there is rapid turnover of nucleic acid, and if there is rapid turnover of nucleic acid, what will happen? Hypoxanthine will convert into xanthine, and xanthine will convert into uric acid. So first problem, one of the problem is hyperuricemia. So see the pathophysiology. Pathophysiology of tumor lysis syndrome. So here there is rapid destruction of large number of malignant cells, and because of that there is rapid turnover of nucleic acid. Clear? And because of rapid turnover of nucleic acid, what happens? We discussed this, that there is hypoxanthine. Hypoxanthine will convert into xanthine, and xanthine will convert into uric acid. So what's the problem? These patients are going to have, first problem, these patients are going to have hyperuricemia. So can you see what is the dyselectrolytemia? It can lead to hyperuricemia. Second problem, whenever there is destruction of large number of cells, there is release of intracellular potassium, and if there is release of intracellular potassium, these patients will be having hyperkalemia, and you know, because of this hyperkalemia there is increased risk of arrhythmia. So second problem, there is release of intracellular potassium. intracellular potassium, and because of that there is hyperkalemia. Clear? So what's the second problem you can see here? There is hyperkalemia, and because of this hyperkalemia, the patients are going to have increased risk of arrhythmia. So it is going to increase the risk of arrhythmia. Next, there is release of intracellular phosphate. So if there is release of intracellular phosphate, this intracellular phosphate combines with calcium, and if it is going to combine with calcium, the patient will develop what? Hypocalcemia. Now see, this calcium and phosphate, it is going to deposit in the renal tubules, and because of deposition of these into renal tubules, these patients might develop what? Renal failure. So the next problem is there is release of intracellular phosphate. Clear? And this phosphate is going to combine with calcium, and if it combines with calcium, what's the effect? Yes, there is hypocalcemia. Clear? Now what happens? This calcium phosphate, it is deposited in the renal tubules. So deposition in renal tubules. Clear? And it can lead to what? Renal failure. So it can lead to renal failure. So there is renal failure. Now see, there is release of intracellular phosphate. So because of that release, what else is there? It leads to hyperphosphatemia also. So there is hyperphosphatemia. Clear? And in these patients there is deranged oxidative metabolism. Because of this deranged oxidative metabolism, what is the problem? There is lactic acidosis. So there is deranged oxidative metabolism, and because of this deranged oxidative metabolism, these patients are having lactic acidosis. Clear? So this is the famous question which is asked frequently almost every year in one of the exam, that what are the dyselectrolytemias which are seen in tumor lysis syndrome, or which of the following dyselectrolytemia is not seen in tumor lysis syndrome. So there is increased turnover of nucleic acid leading to hyperuricemia, release of intracellular potassium, hyperkalemia, intracellular phosphate release, hyperphosphatemia, it binds with calcium leading to hypocalcemia, and there is deranged oxidative metabolism leading to lactic acidosis. Simple. So this is the pathophysiology. Now it's very easy to understand the management. Now see the problem here. There is deposition of calcium phosphate in the renal tubules. Clear? Which can lead to renal failure. So how we can prevent this deposition? If we go for dilution. Dilution means if we go for aggressive rehydration. So what is the first step here? In management, we go for aggressive rehydration. Clear? So we go for aggressive rehydration to prevent the deposition of renal tubules. Second, this patient is having lactic acidosis. So for management of lactic acidosis, what we are going to give? Soda bicarbonate. So we give sodium bicarbonate for lactic acidosis. Now for hyperuricemia, we discussed that there is one drug which blocks both of these steps. It blocks the conversion of hypoxanthine to xanthine and xanthine to uric acid. And what's that agent? It's allopurinol. So we can give allopurinol. And what is the second agent which can be given? It is the rasburicase. Clear? So how to remember? R recombinant UR urate oxidase. Rasburicase is recombinant urate oxidase, and it causes ex vivo enzymatic degradation of uric acid. It causes ex vivo enzymatic degradation of uric acid. So for hyperuricemia, we can use allopurinol and rasburicase. And if patient is having established renal failure, for this established renal failure, we can use what, or we can go for hemodialysis. Clear? So if we see the management, we have to go for aggressive rehydration, sodium bicarbonate for lactic acidosis. For hyperuricemia, we give allopurinol and respuricase, and if patient is having established renal failure, we go for hemodialysis. So this is how we manage tumor lysis syndrome. Next is hypercalcemia of malignancy. Okay, so there is hypercalcemia in malignancy. So hypercalcemia of malignancy. Clear? So generally, what are the factors which are mainly responsible for hypercalcemia in malignancy? We discussed that in malignancies there are osteolytic secondaries, and if there is osteolytic secondary, what happens? There is release of calcium from bone. So first, release of calcium from the bone, and second, there is increased absorption of calcium from DCT. So these are the two main factors responsible for hypercalcemia. So what are the main factors responsible for hypercalcemia of malignancy? First, there is increased release from bone, increased release of calcium from bone, and second, there is increased calcium reabsorption from distal convoluted tubule, DCT. Okay, when we were discussing the malignancies, and we discussed that the malignancies which are associated with hypercalcemia, there is production of one substance. Okay, so what is the most common cause of hypercalcemia of malignancy? The most common cause is increased release of what? PTHRP. Increased release of parathyroid hormone related peptide. This is the most common cause leading to hypercalcemia of malignancy. Now how we manage? This is an emergency, oncological emergency. So here we have to rehydrate the patient with saline. So first we rehydrate the patient with saline, and after that we have to go for forced diuresis with furosemide. Okay, so the management of hypercalcemia of malignancy, we go for rehydration with saline. This is the emergency management, and forced diuresis with furosemide. So diuresis with furosemide. Clear? This is the emergency management. Second, we use the drugs which can lower the calcium level. And what is the drug of choice? You must be knowing. We use bisphosphonates. And in bisphosphonates, what is the drug of choice? It is the zolendronic acid. Okay. So what are the drugs used? Drugs used to lower calcium level. So it's the bisphosphonates. Clear? And what is the drug of choice in bisphosphonate? Zolendronic acid. We discussed this in RCC. We discussed that in RCC also there is hypercalcemia because of PTHRP, and the drug of choice is zolendronic acid. What are the other drugs? You must be knowing that we use calcitonin. It also lead to hypocalcemia. There is a drug known as plicamycin. Other name is mithramycin. Plicamycin, which is also known as mithramycin. We can give gallium nitrate, and we can use glucocorticoids. Which one is given? We give hydrocortisone. Hydrocortisone. Clear? And what is the relation of this hypercalcemia of malignancy in relation to COVID-19? It has been seen that people who are having deficiency of vitamin D, they are having increased risk. So lots of people started taking vitamin D supplements, and it is prescribed weekly, but some of the people were taking it on daily basis, and because of over intake of what vitamin D supplements, there is increased risk of hypercalcemia. Clear? So you should not use that without the prescription from endocrinologist, and generally it is used weekly. Right? So these are the drugs which are used in hypercalcemia of malignancy. The next condition is typhlitis. Okay, typhlitis. What is the other name of typhlitis? It is also known as neutropenic colitis. So why it is known as neutropenic colitis? Because there is inflammation of colon, which part? Mainly the cecum, in the patients who are having neutropenia. Why patient developed neutropenia? Because this patient was receiving chemotherapy. So patient was receiving chemotherapy, cytotoxic agents were given, and you know what is the side effect? It is going to cause immunosuppression, and because of that there is neutropenia. So the other name of typhlitis, it is also known as neutropenic colitis. What is the other name? It is also known as necrotizing colitis. Neutropenic colitis, necrotizing colitis. Now see which part of the colon is mainly involved. So if you see this diagram, there is mainly involvement of what? Cecum, and sometimes there is involvement of ileum. So since there is involvement of ileocecal area, this is also known as ileocecal syndrome, and mainly there is involvement of cecum. So there is inflammation of cecum, that's why it is known as cecitis. Okay, so what are the other names? It is also known as ileocecal syndrome because of involvement of ileum and cecum, and mainly cecum, so the other name is cecitis. Now why typhlitis is seen? So patients who are receiving chemotherapy with cytotoxic agents, and these cytotoxic agents are going to cause immunosuppression. Clear? And because of that, what will happen? There is immunosuppressive effect. So these patients are having neutropenia, and since the patient is going to develop neutropenia, because of neutropenia there is increased risk of infection. So if there is increased risk of infection, and because of this infection there is inflammation. So where is that infection and inflammation? Mainly involving the colon, which part? Cecum. So this is typhlitis, also known as neutropenic colitis, necrotizing colitis, or cecitis. These are the names. Now generally in which patient it is seen? It is more common in children. So you have seen the malignancies in children where we give chemotherapy. Common malignancies ALL and AML. Right? So it is most commonly seen in children receiving chemotherapy for ALL, acute lymphoblastic leukemia, AML, acute myeloid leukemia. Now it's very easy to remember the clinical features. So can you see, here is the inflammation, where in the right lower quadrant there is infection and inflammation. So what are the problems? These patients will be having fever, there is pain in right lower quadrant, there is tenderness, and since there is colitis, these patients have diarrhea. What kind of diarrhea? There is bloody diarrhea, right? So see, what are the clinical features? So these patients have, because of infection and inflammation, there is fever, there is right lower quadrant pain and tenderness, and there is diarrhea. What kind of diarrhea? These patients have bloody diarrhea. Clear? Now see the effect of this inflammation. If you see the wall of cecum, this wall is thickened. So what? There is thickened cecal wall. And how we can visualize? Yes, it can be visualized by radiological investigations. So how you can make the diagnosis? You can make the diagnosis by ultrasound or by CT. So how we are going to make the diagnosis? There is thickened cecal wall. It can be visualized by ultrasound or CT. Clear? And since there is infection, and what is the good thing, that most of the patients are going to improve after medical management. So what's the mainstay treatment or mainstay of treatment? Is the medical management. So see the management. Most patients improve after medical management. Clear? So most patients improve. And generally what we give, since there is infection, so we are giving antibiotics. Clear? So antibiotics are given. Now, what are the indications of surgery? Imagine you are giving antibiotics, but there is no improvement within 24 hours. And the other name of this condition is necrotizing colitis. So that's why in certain patients there is perforation, and if there is perforation leading to peritonitis, we have to operate. So what are the indications of surgery? Indications of surgery. So first, if there is no improvement within 24 hours of antibiotics, within 24 hours of antibiotics, or patient is having perforation peritonitis. So there is perforation, right? So this is how we manage the typhlitis, which is also known as neutropenic colitis. Now we are going to discuss superior vena cava syndrome. So this is superior vena cava syndrome. Okay. So what happens in superior vena cava syndrome? In superior vena cava syndrome, there are clinical manifestations caused by obstruction of superior vena cava. And whenever there is compression or obstruction of superior vena cava, what happens? There is severe reduction in venous return from head and neck, from upper extremity, and from upper chest. So what are the consequences? See, now here you can see that this is the superior vena cava, clear, which is draining into right atrium, and here you can see that this is the brachiocephalic vein, and you can notice here that there is a tumor. So generally in this location, which tumor is there? It is mainly caused by carcinoma lung, and we discussed which type of carcinoma lung. It's because of central tumor, and we discussed central tumors are small cell lung cancer and squamous cell carcinoma. So most commonly this superior vena cava syndrome is because of carcinoma lung. Which type? Small cell lung cancer. Now see, this tumor start compressing the superior vena cava, and because of that there is severe reduction in venous return. And if there is severe reduction in venous return, these patients will be having swelling. In which region? Head and neck. In which region? Upper chest. And in which region? In the upper extremities, right? So here you can see the tumor is obstructing superior vena cava and brachiocephalic vein. Because of this, what else you are going to notice? You are going to notice that these veins are very prominent. Which veins? Internal jugular, here subclavian and axillary. So here you are going to notice that there are dilated internal jugular vein, dilated subclavian vein, and dilated axillary vein. Dilated axillary vein. Clear? Second problem, whenever there is compromised return or decreased venous return, these patients are having edema. The venous blood is containing deoxygenated blood, and because it contains deoxygenated blood, that's why these patients will be having what? Cyanosis also. So there is edema, there is cyanosis. Second problem, if this SVC obstruction is occurring over a long period of time, so what will happen? There is formation of collaterals. So collaterals will be formed between superior vena cava and inferior vena cava. That's why you will notice that there is presence of dilated veins over the anterior chest wall, mainly on the right side. So here you can see that there is presence of what? The dilated veins. So these are what? Dilated veins or collaterals, and these collaterals are formed between superior vena cava and inferior vena cava. So this is the basic concept. Now we are going to discuss in detail the superior vena cava syndrome. So in superior vena cava syndrome, there is severe reduction in the venous return from head and neck, upper chest, and upper extremity. What's the most common cause? The most common cause of superior vena cava syndrome is the carcinoma lung. Now comes the question, which type? Yes, so most common malignancy responsible is small cell lung cancer followed by squamous cell carcinoma. And if we are talking about most common cause of superior vena cava syndrome in young adults, then it is malignant lymphoma. So what's the most common cause of superior vena cava syndrome in young adults? Clear? And it is malignant lymphoma. So this is malignant lymphoma. Now see the clinical findings. It's very easy to understand. So you saw that what there is edema of head and neck, upper chest and extremities. In head and neck portion, you are going to notice edema mainly around the eyes. If you examine and ask the patient, this patient is having nasal stuffiness also, and this patient is having epistaxis also. If you see the oral cavity and you ask the patient, there is swelling of tongue also. Okay, so see what are the clinical findings here. These patients have swelling, and this swelling is more prominent around head and neck and especially around the eyes. Clear? In head and neck, what is the other problem? These patients have nasal stuffiness, and because of this, venous congestion is there. These patients might have epistaxis. Clear? Because of edema, these patients have edema of or swelling of tongue also. So there is swelling of tongue. There is impaired venous return from head and neck. So what's the problem? These patients have headache. These patients have dizziness, syncope. So there is headache, dizziness and syncope. Clear? Another problem. Sometimes when the malignancy is advanced, and if the malignancy is advanced, it is going to compress the midline structures. So suppose this tumor is located in superior mediastinum and it is going to compress what? The midline structure. What are those midline structures? Trachea, esophagus and recurrent laryngeal nerve. So whenever there is compression of trachea, there is dyspnea, esophagus, dysphagia and recurrent laryngeal nerve. These patients will be having hoarseness of voice. But this is seen in advanced malignancy when there is compression of midline structures. So what? If there is compression of trachea, there is dyspnea. Compression of esophagus, there is dysphagia, and compression of recurrent laryngeal nerve, so that is leading to hoarseness of voice. Simple. These are the clinical findings. Now see what are the examination findings. So on examination here you can see that on examination we noticed what? That there is edema of face, neck and upper chest. So there is edema, first problem, face, neck and upper chest. Second, there is bluish discoloration. So what's the problem? Cyanosis. And if you see, can you see here? There is presence of collaterals. So dilated veins. What is the location of dilated veins? You noticed internal jugular vein is dilated, subclavian vein, axillary vein is dilated. So dilated veins in neck, chest and mainly the anterior part of chest. Okay. So there are presence of dilated veins where? In the neck and anterior chest. Clear? Why? Because there is formation of venous collaterals between superior vena cava and inferior vena cava. Clear? So here you are going to notice the dilated veins over anterior chest wall. These are the manifestations. Now where is the location of tumor? In the mediastinum. It is carcinoma lung. So generally investigation of choice for diagnosis of superior vena cava syndrome is CT. So how we are going to make the diagnosis? Investigation of choice for diagnosis of superior vena cava syndrome, and that's CT. Clear? Now if we go for chest x-ray, what you are going to see here, since the tumor is here, there is widening of mediastinum, and this widening of mediastinum is more common on which side? Right side. So on chest x-ray there is widening of superior mediastinum. Superior mediastinum, and generally there is widening on right side. Clear? Now how we are going to manage? See, the management is dependent on the type of tumor, means it is dependent on the etiology. So there are two presentations. Sometimes these patients are brought to you in emergency. Why? Because there is tracheal obstruction. So if there is emergency presentation, tumor is going to involve the trachea or infiltrate the trachea. Because of that, this patient is having what? Dyspnea. So here we are going to relieve the obstruction. So in emergency, we have to perform a tracheostomy, right? So see, the treatment depends on underlying cause. If there is life-threatening complication like tracheal obstruction, so for life-threatening complications, emergency surgery is required. And what we do? Generally, we perform the tracheostomy. Okay. Generally, this tracheal obstruction is seen in which kind of mediastinal masses? It is caused by superior mediastinal masses. So we perform emergency surgery. Otherwise, treatment depends on the underlying cause. So we go for surgery also, we go for chemotherapy also, and radiotherapy also. So now see, in which cases we give radiotherapy, in which cases we give chemotherapy, and in which cases we go for surgery. Okay. So generally radiotherapy is given for non-small cell lung cancer and metastatic solid tumors. So if there is metastatic solid tumor or non-small cell lung cancer, we go for radiotherapy. Chemotherapy, we go for small cell lung cancer or lymphoma. So if the patient is having small cell lung cancer, because we discussed that small cell lung cancer is most responsive to chemotherapy, right? And whatever the cases are left, so for rest of the cases, we go for rest of cases, we go for surgery. Clear? So this is how we manage the superior vena cava obstruction. So this is all about oncology.